I'd like to introduce Dr. Seyedman.
I'm absolutely delighted to be here because it's a long time coming that ketamine makes its way into Israel. I'll just start with the slides. I'm a New York City psychopharmacologist. I've been prescribing ketamine for more than 10 years already in my practice. I treat mostly treatment-resistant patients, and ketamine has been absolutely essential. So today, what we'll speak about in these 15 minutes is, first, I'll describe approaches to difficult-to-treat depression. Second, I'll review the rationale and major findings supporting the use of ketamine for depression and suicidality. And third, I'll highlight some novel therapeutic strategies. I think because most of us are psychiatrists here, I don't have to belabor this point. The theme here is that depression is horrible, and treatment-resistant depression, as we all know, is a bear. It is very tough, and it is very disabling. And when you look at the numbers of lost life years, it blows away everything else. It is really horrible. This slide just makes the point that unlike what we used to teach, that depression is almost like pneumonia, we now understand depression is far more like asthma or diabetes. This is a chronic condition. People fall into depression, they come out of it, but then there's almost always relapse, recurrence. This is something people struggle with, and that's not a big surprise, right? No one's surprised that people have multiple migraines or seizures. Well, the same thing with depressions. This is a recurrent illness. When it presents itself in someone's brain, oftentimes it's there. It's there for life. So how do we treat it? Again, we all know this. Most of our treatments are monoamine based. Monoamines mostly being serotonin, norepinephrine, and dopamine. And so we use SSRIs, SNRIs, atypical antipsychotic, augmentation, tricyclics, and MAO inhibitors. The problem, as many of us know, and I won't go into the numbers, but there are deep problems with this treatment for many people, although some people do beautifully, right? You give them 20 milligrams of Prozac and you're done forever. That's the minority. There are modest effect sizes in large studies versus placebo. There are adverse events, especially sexual side effects. There's a slow onset of action, and it doesn't really work for suicidality. Certainly getting the depression better works for suicidality, but the drugs themselves do not seem to have a suicidal effect. I put this up here almost for all of us to roll our eyes a little bit, because these are the FDA-approved therapies for the difficult-to-treat depressions, and we don't do most of these things, right? So again, I mean, we can speak somewhat about what it takes to get FDA approval, but it's hundreds of millions of dollars, very expensive, and so it's rarely done for things like treatment-resistant depression. But what is approved for treatment-resistant depression is ECT, TMS, vagal nerve stimulation, right? And we all know that we rarely use these things. Olanzapine, fluoxetine combination, I'm sure we remember when that was released, and I don't think anyone prescribes that combination. If we're going to give that, we'll give it separately. But as most people know, it comes as one pill with both of those drugs. And then more commonly is adjunctive atypicals, right? And the ones that have been approved are the Abilify or aripiprazole, the Seroquel, quetiapine XR, and the brexpiprazole. And then finally, the adjunctive S-ketamine nasal spray did get the TRD approval. This is what we really do in the real world. And the first thing, and we should never forget, the first thing is, and this, by the way, is off the top of my head. This is what I do in practice for my treatment-resistant depressives. You raise the dose. Usually you raise the dose. If you're getting a partial response to a low dose, just go up. Second, you add a little bit of Wellbutrin or bupropion, or you can add a tricyclic. Third, you can add some lithium or thyroid or buspirone. Fourth, adjunctive anticonvulsant mood stabilizers, so lamotrigine or Lamictal or Depakote, valproate. again, these are for the more, we're talking about non-bipolars for now, but it turns out that for many people with truly treatment-resistant depressive conditions, anticonvulsants or these mood-stabilizing anticonvulsants are often very helpful. We add atypical antipsychotics. Again, we don't do that right away because of the challenges on having someone on these meds for a long time, but it certainly works. Switching to MAO inhibitor is very close to my heart. It is a brilliant and often transformative treatment that is rarely used in Israel. It's used here and there, but it's not used nearly enough. And we could talk about this at great length. These are terrific meds. They're reasonably easy to use, and they should be used more. And finally, there's ketamine. And the data is clear now. IV, IM, and IN, right? Intravenous, intramuscular, and intranasal ketamine is quite effective for treatment-resistant depression. Now, on a side issue, how do we think about it? Well, in this middle bar, that's how it's always been, right? You go midbrain serotonergic neurons, which send serotonin up to the cortex and hippocampus. And if you affect those in someone in a depressive episode, you can redirect them out of depression. You can put them into remission. Probably the minority, but it really does work. The new thinking, and again, that's why we're here. We're talking about how might ketamine be different. The new thinking is starting up top in the cortex, right? The glutamate is the most important cortical neurotransmitter, and it's essentially going top down. Cortical impulses reaching down into midbrain and into whatever dysregulated networks are out of control in a depressive episode. So what is ketamine? Well, ketamine, and Dr. Drescher will be speaking about this in a little bit, but ketamine is a dissociative anesthetic that is a derivative of PCP. It blocks the NMDA receptor. It was approved in 1970, so it's been around a while. And importantly, because it was approved as an anesthetic, there was no incentive to spend the money on getting approval for other conditions. It's been studied extensively as a model of psychosis. And in fact, it's from one of those groups at Yale, led by John Crystal, that the modern era of using it as an antidepressant developed. And it's a substance of abuse. Again, it's an NMDA channel blocker. I have this slide up because there are actually multiple new medicines that are going after targeting the NMDA receptor. But since we won't be speaking about that, I'll skip over this. But it's very interesting. Okay, here's the meat. Here's the meat of my talk. Take a screenshot of this because this is the data. So ketamine, John Crystal in the mid-90s gave ketamine to a bunch of resistant depressives. They got better. It was an open trial. It wasn't systematic. It was an interesting finding, but it really went nowhere until 2006 when Zarate showed this. And essentially, he gave these 17 subjects, 17 people with treatment-resistant depression, an infusion of ketamine. With an infusion of ketamine, if you want, and this is Hamilton on the left side. So the Hamilton, and these are minutes. Okay, so again, it separates from placebo 110 minutes after infusion. And then the real separation happens at day 1. Now, the beauty of this is that it's not 17 patients, it's hundreds of patients at this point. This has been replicated multiple times. This works, and these are treatment-resistant patients. As many of you know, and I've done studies in testosterone with treatment-resistant patients. These are really tough patients. They do not get better. There is very little placebo response in treatment-resistant patients. These are the toughest of the tough, and lo and behold, a day later, they're better, dramatically better. This is very significant. I mean, there's still average Hamilton is in the 10 range, but they're dramatically better, especially when you compare it to the placebo group. The second very important point is that a week later, they're back to where they were. I mean, maybe they're a little better than the placebo group, but this is a rapid, dramatic effect that is non-durable. It goes away a week later. Here, down on, and these other slides show about the same thing, right? So at day one, with the Hamilton percent response, or often we call responders those who have a 50% or more drop in their Hamilton. So this is the percent of the subjects who had that much of a drop. And so again, 71%. Of course, placebo was tiny because treatment-resistant depressives do not get much of a placebo response. So again, 70%, and that has borne out over time. Many of the studies show 70+%, 70 to 80% response rate at day one. Here we have a 72 subject study where patients were randomized to midazolam, which is a benzo, which of course, as you know, probably gives you a point or two lowering on the anxiety item and the sleep item. But that's the control condition, though it's not a real control because something is happening with a benzo, and versus ketamine, which clearly you see at day one, they got the effect. Here, they didn't even lose the effect very much by day 7. But well, see here, it was less of an effect at day 7. It was still significant in responders versus midazolam, but I think the field mostly accepts that you get a few good days and then it slips away. Here's a nice study looking at dose response. And so because it's not clear, and in the beginning it was all anecdote. What dose to use and why does it work? So here, multiple doses were given. The first, of course, the midazolam arm, which is not ketamine, it's just the benzo. And this is a HAM6, so an abbreviated Hamilton. And again, a bit of a placebo response, not much. But the nicest response is down here at the bottom, the 0.5. 0.5 milligram per kilogram has defended itself as the best dose, at least the best starting dose for treatment-resistant depression. And it separates clearly here from the others. The 1 milligram per kilogram isn't terrible. And so this is kind of the range we like to use, somewhere between 0.5 and 1. We start at 0.5 and we inch up if we're not getting much of a response. This is a scale of the dissociation. And so clearly the dissociation, this experience of being almost out of your body, or this strange change in consciousness that people with ketamine experience. So that's clearly more with the 1 milligram. An open question is, to what extent is that experience related to the antidepressant effect? And that's a big discussion, a big open discussion. And there's a very interesting long history of ketamine use as a psychedelic. We won't speak about that today. Finally, the suicidal ideation. We have very few meds. I mean, clozapine and lithium probably reduce suicidality, but nothing like ketamine. Ketamine is a thing of beauty. And I have not infrequently had suicidal patients sitting in front of me and go to the safe, get the ketamine and hand it to them and have them do it right there in front of me. And it is a thing of beauty to see that suicidality just lift. And it's demonstrated very clearly with IV ketamine in suicidal ideation. So this is in clinician-reported suicidal ideation, ketamine versus control. In the MADRS item 10, which is the suicide item, again, ketamine versus control. And in the HAM-D item 3, ketamine versus control. Clearly, at day one, the suicidality drops, which, as we all know, may be enough to save someone's life. And to be honest, is most of the reason why I'm doing this and helping to bring ketamine to Israel. I think we'll hear from Dr. Nazir that there are upwards of 1,000 ketamine clinics in North America. This is standard of care now. Almost certainly some people in Israel who are not able to get this medicine have died from suicidal behavior for lack of ketamine. So I have no doubt that this will save lives once it's more widely available in this country. We don't have time to talk about S-ketamine, but S-ketamine is available in this country. It was FDA approved in 2019, and in 2020, it was approved for suicidal ideation. There are challenges with using S-ketamine. It requires a REMS program. I won't go into all of this, but essentially you have to go into the clinic and stay there for 2 hours and do the nasal spray. But far bigger problem is that you can't dose it correctly. There are only 2 doses, and I believe in Israel it's not so easy to get into these clinics. I like this study a lot, and this should hit home for many of us treating the toughest of the tough, because when they're tough, you send them for ECT. And so this study, treatment-resistant, 2 or more adequate trials of antidepressant, and they were randomized to receive either ECT or ketamine. So, and it was a nice big study. So 600 to 800 screened, 200 randomized. There are 200 in the ECT arm, 200 in the ketamine arm. For ECT, they got 9 treatments. The ketamine, they got 6 treatments, which is the standard, right? 2 a week for 3 weeks. And the main outcome was at day 18. And there was a long-term arm to this, but all right. So first, the overall effect is quite clear. Again, we all know ECT works, right? ECT is a terrific, effective treatment for treatment-resistant depression. And I think most of us have a feeling that it works really nicely for old people, right? It's a little old lady kind of treatment. I always thought maybe that's because we don't want to send young people for ECT so quickly with maintenance and having to keep a job and the rest of it. But it's certainly a good treatment for older people, and that's somewhat borne out by this data. So if you look at the blue dots, these are those randomized to ECT, and this is their MADRS. This is how depressed they were at baseline. These orange dots are those randomized to ketamine, about the same. The blue dots, so obviously dropping in the Hamilton is getting better. So with ECT, all of these blue dots drop down here. So clear effect of ECT. Still, these are treatment-resistant depressives, so some of them are not getting better. And lo and behold, similarly, with ketamine, they drop, right? We got a nice bunching here. And we see this over time, the drop in the MADRS. These are not significantly different. Again, we've got about 100 in each group. Ketamine essentially is non-inferior. It does okay against ECT. But here's the interesting stuff. In the 18 to 50-year-old age group, the ECT response is 50%. The ketamine response is 61%. It's especially effective. And this is why we love studies with big numbers, right? You can stratify. You can look at specific questions like this. Again, below age 50, ketamine, and this is not statistically significant, so I will not say that ketamine is better, but I think we can strongly say it's at least as good. It looks non-inferior to ECT in these younger folks. In the older folks, 51 to 85, the ECT response is 77%, ketamine response 37%, which supports our intuition that ECT seems to work well for older folks. So in summary, ketamine demonstrates, and this is out of McIntyre's American Journal summary, which is good reading. Anyone interested should get this. Roger McIntyre had a panel that went over all of the evidence. Ketamine demonstrates rapid efficacy for treatment-resistant depression. Second, intranasal S-ketamine and IV racemic ketamine have the most evidence in TRD, with insufficient evidence for oral, subcutaneous, or IM ketamine. And also we can add to IN, intranasal. However, it works. You know, anecdote matters. And those of us who do this, we see it works. Doesn't work for everybody, but it certainly works for some people. And it's highly unlikely that it's placebo response. Intranasal S-ketamine demonstrates efficacy for up to a year in adults with TRD. Evidence for long-term efficacy, safety, and tolerability of IV ketamine is insufficient right now, although we're getting there. We're getting there, especially with all of these clinics. Finally, S-ketamine and ketamine may attenuate suicidal ideation in adults with MDD and TRD. Guidance. Ketamine's well tolerated. Key areas of safety include the psychiatric, which essentially is the dissociation, and of course the risk for psychosis, which happens in choosing who comes in. You really want to avoid those with psychotic illness. Neurologic, abuse, GU, and hemodynamic are issues that will be fleshed out over time, and Professor Drescher will speak about this. Ketamine risk for predisposing alcohol or substance abuse disorder is unknown, and ketamine should only be implemented in settings with multidisciplinary personnel, including expertise in the assessment of mood disorder, that means psychiatrists. And I would add to that emergency personnel, or people who know how to handle medical emergencies, though they are vanishingly rare. REMS is required in some countries, and Israel is one of them, as is the US. Thank you for your attention.